Now, the first thing I'll tell you about today's presentation is that it will not be on an exam. This is the kind of thing that I don't think we can test you on in a multiple choice format, because you'll be hearing something about the human side of medicine. And I know that's why most of you came to medical school in the first place, to deal with patients, to make their lives better. And I think today's presentation really will address that very critical area of your education. So I'm very pleased that Debbie, Heather, and Logan have come again this year to share their story with us. Before I introduce them, I'm going to tell you just a little bit about Miller syndrome, the condition that affects Heather and Logan. So Miller syndrome is also known as postaxial acrofacial dysostosis. It's a mouthful, but it does help to describe the condition. It's a dysostosis, so a malformation of bones. Acro refers to the extremities, so it affects in particular the extremities, the hands and feet. Facial, there are facial manifestations as well, and it tends to be postaxial, so behind the axis, affecting especially the ulna, the fibula. So there are craniofacial malformations, limb malformations, and I'll show you a picture in a minute. Also conductive hearing loss and cleft palate. These are all considered typical features of this condition, Miller syndrome. Now, back in 1977, when Heather was born, there were only 3 or 4 cases of Miller syndrome in the literature. So imagine that you're counseling a family that has just had a child with this condition. What recurrence risk would you give them? 3 or 4 cases known in the literature, no recurrences known. What recurrence risk would you give them? Mr. Klein says very low. Zero? Not known. Actually, in this case, the right answer is we don't know. When there are so few cases, so little data, we really don't know what the recurrence risk is. We don't know what the mode of inheritance is. We don't know what the mechanism is at that point. So the right answer in that case is we really don't know. It could be inherited, there could be elevated recurrence, but we simply don't have enough information to establish a recurrence risk. Now, as you'll learn from Debbie, that was not the answer they were given. So this is a picture of Heather, published in the Journal of Pediatrics in 1979, showing some of the features of Miller syndrome. So you can see some of the craniofacial features, downturning of the lower lid, eyelids, also missing digits in the hands and feet. Here's an X-ray showing that in the hand and foot in Heather, and also hypoplasia or underdevelopment of the ulna and the radius, causing forearms to be rather short. This is a picture of Heather with her brother Logan. This was the first known recurrence of this condition in a family anywhere in the world, so that was also reported in the Journal of Pediatrics. And this is when I first learned about Heather and Logan. They were seen in our pediatric genetics clinic, and I remember the discussion about them, whether they had what was then called Miller syndrome, a new syndrome, or some alternatives, Nager syndrome, Treacher-Collins syndrome. So there was really some discussion as to what the diagnosis might be. But you can see that Logan has some of the same craniofacial features as his sister. This is a picture of Heather when her arms were splinted prior to one of her corrective surgeries to try to loosen up the joints. Heather and Logan, between them, have had more than 50 major surgeries thus far in their lives. Here's a later picture of Heather playing with Play-Doh, is that right? Yeah. Yeah. And then here's a picture of her brother Logan, and again you can see the limbs very, very similar to those of his sister. This is Heather's high school graduation picture. Shortly after she graduated, she had reconstructive jaw surgery, and you can see it made quite a difference. This is another little girl with Miller syndrome named Bridget. And you can see very, very similar craniofacial and limb features. Very, very similar to those of Heather and Logan. And this is Bridget, photographed here with Logan. And this is the other family in which Miller syndrome has recurred. This is a family from New Zealand, so two siblings, both affected with Miller syndrome. Again, very characteristic features, shown with their unaffected sister here. So this is the pedigree, Logan and Heather shown here with their unaffected parents. They both have Miller syndrome. Now another feature that both Heather and Logan share is chronic bronchiectasis, where the large airways are widened. They undergo destruction as a result of recurrent infections and recurrent airway infections. The bronchiectasis, which they've had all their lives, is not part of Miller syndrome. So one of the questions was, why do they have both the features of Miller syndrome as well as bronchiectasis? Now, an interesting thing about the family history is that Heather and Logan's first cousin, Brandon, had cystic fibrosis. Cystic fibrosis accounts for about 1/3 of bronchiectasis cases in the United States. So one of the questions that you would ask with this family history is, what's the risk that the mother here, that is the aunt of the affected boy, what's the risk that she would be a carrier for cystic fibrosis? So you should be able to do this in your heads. What's that risk? First of all, what's the risk that the mom is a carrier? She has to be. So what's the risk that one of the parents here is a carrier? Well, one of them has to be a carrier. So what's the risk that this person, the mom of Heather and Logan, Debbie, what's the risk that she would be a carrier for a CF-causing mutation? 50%, right? Yeah, 50% that she would be a carrier. So now about 12 or so years ago, we collected DNA from the family members. We sent them off to my colleague Gary Cutting at Johns Hopkins University, who's a CF specialist. They were tested, and it turned out that indeed Debbie is a carrier of the most common cystic fibrosis producing mutation, delta F508, as are both Heather and Logan. But the paternally transmitted chromosome was perfectly normal. No mutations in CFTR. So that's not sufficient to account for their bronchiectasis, because heterozygotes with delta F508 do not typically have bronchiectasis, and certainly not very early in life. Also, their sweat chlorides were normal, so they did not have the typical features of cystic fibrosis. So at that point, in fact, in 2009, just a couple of years ago, we really didn't know the cause of Miller syndrome. We weren't even sure if it was actually genetic. But then, a couple of years ago, it became feasible to do whole genome sequencing. And in fact, Heather, Logan, Debbie, and Heather and Logan's father became the first human family ever to have their entire genomes sequenced. Because just 2.5 years ago, we were able to get genome sequencing for, at that time, about $25,000 a piece. Remember that the first human genome cost $3 billion. So we got DNA from each family member. We did whole genome sequencing using a company called Complete Genomics. And basically, we're not going to go into this in any detail, but essentially you chop the DNA up into little fragments. You sequence them with a high-throughput sequencer. You get millions and millions of these fragments sequenced from a given individual. And then the question is, how do you put all of this together? So we use the Human Reference Genome Sequence, the one published back in 2003, because that gives us essentially an anchor point that we can then align those sequences to. And so we have multiple reads for each nucleotide position. So here, for example, is a C. There's one difference. There's a T, but that's almost certainly a sequencing error because all of the other reads were T's. For this nucleotide, we see that about half and half are C's and A's. So that's a heterozygote for C and A. So in this case, we have, for this example, rather low coverage, just 11-fold. Typically we have 30 to 50-fold. But it allows us then to infer the composition at each base position. So that work led to a paper that appeared in Science last year. Among other things, we were able to establish for the first time the human mutation rate directly in a family. And as a result of the sequencing work, both exome sequencing, where you sequence the exons, as well as the whole genome sequencing, 2 autosomal recessive conditions were identified in Heather and Logan. So the first was the gene that causes Miller syndrome. It's a dehydrogenase, not really a good candidate for a bone malformation syndrome. But it was established that both of them are compound heterozygotes for a mutation in DHODH, as are several other patients with Miller syndrome. So this was identified then as the cause of the disease. The other interesting thing that came out of that sequencing was that Heather and Logan both have primary ciliary dyskinesia. As a result of a mutation in a gene called DNAH5. This encodes part of the dynein motor protein that is responsible for ciliary movement. So if you don't have that motor protein, your cilia don't move the way they should. They can't clear the lungs of infections, accounting for the lung infections that Heather and Logan have both had. Also, it helps to account for some degree of situs inversus, especially in Heather, where the organs are misplaced. Because I think, as you know, you need normal ciliary movement as an embryo to get organs placed where they should be, the proper left-right orientation. So lacking that, organs tend to be misplaced, and you can actually have complete reversal or situs inversus. And as I mentioned, this also allowed us to establish the human mutation rate, which has now been verified in several subsequent studies. So this is the picture now showing that both Heather and Logan inherited 5 disease-causing mutations, 2 from their father, a Miller syndrome and a primary ciliary dyskinesia-causing mutation, and 3 from their mother. So this is vanishingly improbable. Each of these are rare events, yet they all occurred. Just showing what happens sometimes in the genetic lottery. But both are compound heterozygotes then for these 2 autosomal recessive conditions. So we were surprised, actually, and I guess pleased, that when this was published about 1.5 years ago, it actually came out. It was on the front page of the New York Times. So it got a lot of attention. This is one of my favorite pieces, though. This was in Discovery magazine last year, and it's a picture of Logan painting a version of his own chromosomes. And as you'll learn, Logan is an artist, and I think this is really kind of a nice depiction of one of his interests and the genetic discovery. So this was also in the local papers, and one of the things that came out as a result of that was that the family identified themselves, and some of you may know that Debbie and I share the same last name. So as it turns out, we met completely coincidentally 7 years after I learned about Heather and Logan in the genetics clinic, probably the only party conversation that included the phrase postaxial acrofacial dysostosis ever. I'm very happy to say that I have a very close relationship with Debbie. And so really this whole exercise for me and for Debbie and her children was one of very personal genomics. And so now I'm very happy to introduce Debbie to tell you about her story. So please join me in welcoming her.